Usually, when we talk about a medical diagnosis, there is this comforting expectation of precision. Like, you break your arm, the x-ray shows a jagged white line, and the doctor just points to the screen.
Right, it's very binary, broken or not broken.
Exactly.
We prefer our medical problems to be visible.
Yeah.
It gives us a very clear enemy to fight.
But then you step into the world of autoimmune conditions, and that metaphorical x-ray machine just, well, it prints out static. We are looking at a diagnostic landscape that is incredibly murky.
Yeah, murky is definitely the right word for it.
And today's exploration tackles a medical mystery full of exactly those kinds of contradictions. We are taking a really close look at lichen sclerosus, which is often abbreviated as LS.
Right.
For those of you who might be unfamiliar with this is an underdiagnosed autoimmune, inflammatory, and severely scarring skin condition. It predominantly affects the genital area.
And while both sexes can get it, it is vastly more common in women.
Vastly. We're talking about intense, severe itching, chronic pain, and skin splitting, especially at the fourchette, which is the bottom of the vaginal opening. It also causes the formation of these very distinct porcelain white plaques on the skin.
And we really need to emphasize that the physical and psychological burden for people living with LS is massive.
Yeah.
Because left untreated, it leads to severe scarring. I mean, the actual loss of normal anatomy, like the fusion of the clitoral hood, it causes significant functional impairment that completely alters a person's quality of life.
There is just so much to discuss regarding the symptoms and treatments, but our specific mission for this deep dive is to answer a highly debated question, which is, does hormonal contraception influence the onset or progression of lichen sclerosus?
It's a huge question.
It really is, and we have a pretty big stack of sources in front of us to figure this out, including a major 2023 update from the journal Frontiers, plus extensive research from clinics in dermatology and the official patient guidelines from the British Society for the Study of Vulval Disease, the BSSVD, and the British Association of Dermatologists.
But, laying those particular sources out side by side reveals a glaring problem right away.
Oh, absolutely.
The medical literature appears to be completely contradicting itself on the role of hormones.
Okay, let's unpack this. Because the clinical papers seem to point the finger at birth control, while the official patient guidelines explicitly say birth control has nothing to do with it.
Right.
So to understand why hormones are even part of the conversation for an autoimmune skin condition, we kind of have to look back at how doctors originally attempted to solve the LS puzzle.
Yeah, historically, the medical community looked at the epidemiology of LS. They basically tracked who was actually presenting with the disease, and a very specific pattern emerged regarding age.
What kind of pattern?
Well, there are two peak ages when lichen sclerosus tends to appear. Prepubertal girls, often in the first few years of life, and postmenopausal women.
Which are two demographics that seem entirely different on the surface.
Totally. But doctors looked for the physiological common denominator, and the answer they settled on was hormones. Specifically, both prepuberty and postmenopause represent physiological low estrogen states. So the original hypothesis essentially wrote itself. They figured low systemic estrogen must be the driving force behind this localized skin condition.
It sounds like seeing a withered plant in the desert, assuming it just needs water, and drowning it, when actually it's a cactus and something else is entirely wrong with the soil.
That is a great way to put it. Drowning that cactus is essentially what the medical field did for decades.
Wow.
Based on that low estrogen hormone deficit theory, the standard medical response was to treat LS with topical hormones.
Just putting it right on the skin.
Yeah. Exactly. Doctors prescribe 2% progesterone, 2% testosterone, and 2% dihydrotestosterone creams to be applied directly to the affected vulvar tissue. They just assumed they were replacing what the skin was starving for.
But looking at the sources, that approach failed completely, right?
It failed miserably.
Yeah.
Randomized controlled trials eventually caught up with the observational theories, and studies proved these topical hormones were no more effective than plain petroleum ointment.
Just Vaseline.
Basically, yeah. One study detailed in clinics in dermatology actually noted that women treated with 2% dihydrotestosterone showed zero clinical improvement in their symptoms.
Zero. And there is a detail in the source material that takes this from a simple failure to an act of harm, which blew my mind.
Oh, the flare-ups.
Yes. Giving these tissues hormones didn't just fail to heal them. In some cases, it triggered flare-ups. Women who had already achieved remission of their LS using proper steroid creams were put on a topical testosterone maintenance therapy for 24 weeks. And the result was that their symptoms and the physical appearance of the disease worsened compared to patients who were just given a placebo.
It's wild.
Why would the tissue actively reject this if the whole theory was that it was hormone-starved?
Well, the Frontiers update gets incredibly granular about the biology here, and it explains why the cactus was drowning. Researchers mapped out the hormone receptors in the epidermis and dermis of women with vulvar LS,
Right.
and they found the expression of estrogen receptors in LS skin is actually comparable to that of healthy women. There is no biological deficit of receptors.
So the locks are all there on the doors.
Exactly.
Yeah.
But there is a structural abnormality. So in healthy tissue, you find a specific type of estrogen receptor called receptor alpha. But in LS tissue, that alpha receptor is often absent in the fibromuscular layers.
Oh, interesting.
Right. Instead, a different type estrogen receptor, isoform beta, is highly upregulated.
Okay, let's break down that terminology for a second for the audience. What does isoform beta highly upregulated actually mean for the cells in the vulva?
Okay, think of an isoform as a slightly mutated version of the standard lock. Your body is mass-producing or upregulating these beta locks and putting them on the cell doors.
Okay, I'm with you.
The problem is, even when the estrogen key is inserted into this beta lock, the door doesn't open. The signal just doesn't go through. This variation makes the tissue in LS refractory or entirely resistant to estrogen therapy.
So it is actively ignoring the estrogen.
Completely ignoring it.
So dumping topical hormones on the skin is totally obsolete for treating lichen sclerosus. I mean, they don't work, they have unwanted side effects, and they cause flare-ups.
Yeah, the topical hormone hypothesis is definitively dead.
Which opens up a much more complicated question. If putting hormones on the skin doesn't fix it, could systemic hormones, specifically taking the oral contraceptive pill, be the thing that triggers the disease? Because you are fundamentally shifting the body's entire hormonal landscape when you take a daily pill.
Exactly. The science pivots here from local applications to systemic shifts, and the mechanisms become incredibly nuanced.
Wait, I have to stop here because the premise itself sounds bizarre. The Frontiers update and the Clinics and Dermatology papers cite findings that early onset vulvar lichen sclerosus in premenopausal women is linked to the use of oral contraceptive pills.
Well, we do.
How does a pill designed to prevent pregnancy or clear up acne trigger an autoimmune scarring skin condition on the vulva? Like, what is the actual mechanism connecting a pill in your stomach to a plaque on the skin?
That's a great question. To understand the mechanism, we have to look closely at the localized anatomy of the female genitals. The transition zone from the internal vagina to the external vulva is anatomically unique.
Okay.
As you move from the inside out, there is a natural, marked increase in androgen receptors and a decrease in estrogen and progesterone receptors. So that specific vulvar skin relies heavily on androgens like testosterone for its normal cellular growth, maintenance, and structural integrity.
Meaning the vulva naturally needs androgens to stay healthy.
Exactly. Now, we add the genetic variable. Research shows that in a specific subgroup of individuals who develop lichen sclerosus, their baseline vulvar androgen receptor expression is already abnormally decreased due to their genetics.
Oh, wow.
Yeah, their tissue is fundamentally struggling to capture the androgen signals it needs just to maintain daily health.
So you have a young woman whose tissue is naturally starving for androgens, and she starts taking an oral contraceptive pill.
And many oral contraceptives, especially those prescribed to manage conditions like acne or polycystic ovary syndrome, have potent anti-androgenic properties.
Right.
Their explicit purpose is to suppress androgens systemically throughout the entire body.
Oh, I see. So the pill comes in and shuts down whatever minimal androgens that vulnerable tissue is actually managing to scrape together.
Exactly. The anti-androgenic pill disturbs the already fragile androgen-dependent growth of the vulvar skin. So for a young woman who is genetically susceptible to LS, pulling that systemic hormonal rug out from under the tissue acts as the catalyst. It is the environmental stressor that triggers the early onset of the disease.
So the birth control pill doesn't create the autoimmune disease out of thin air. The anti-androgenic effect creates the perfect storm in tissue that was already vulnerable.
Yes. There is a stark difference between local, topical hormones, which fail as a treatment, and systemic hormonal shifts, which interact with a person's underlying genetics to act as a disease trigger.
And the sources point out a protective twist to the systemic puzzle, too, because not all birth control is anti-androgenic.
Right, and what's fascinating here is how the Frontiers data highlights this divergence. While combined oral contraceptives, particularly the anti-androgenic ones, were linked to triggering early onset LS, contraception methods based on progesterone alone actually seem to be protective against developing vulvar LS.
Really? So a progesterone-only mini pill or a hormonal IUD might offer a protective benefit for the vulvar tissue.
Yeah, the observational data suggests a protective effect. But the researchers noted this benefit is entirely lost the moment the contraceptive is combined with systemic estrogens.
Oh, interesting.
Furthermore, one specific study noted that topical treatment with 8% progesterone induced remission in about 60% of premenopausal patients. Though I should add, it still falls far short of the gold standard treatments we use today.
Right.
Systemically, though, progesterone alone seems to support this tissue, whereas systemic anti-androgens attack its vulnerabilities.
Okay, so if you are listening to this and you have lichen sclerosus and you've just heard us walk through the biological mechanics of how anti-androgenic birth control pills can trigger the onset of this disease, you are going to be incredibly confused when you read the official guidelines given to patients.
Oh, the great guideline contradiction. It is a massive source of frustration for patients.
Here's where it gets really interesting, because I pulled the official Right Decisions guidance and the BSSVD Good Practice Statement. These are the actual documents a doctor hands you in the clinic.
Right.
And they explicitly state, in bold letters, lichen sclerosus is not caused by the menopause, hysterectomy, the oral contraceptive pill, or HRT. They flat out tell patients that the pill has absolutely nothing to do with it. So how is a patient supposed to navigate a direct conflict between the clinical journals and their doctor's handouts?
It's tough. But from a public health and medical communication standpoint, there is a distinct reason this divide exists. Clinical guidelines, like those from the BSSVD, are written for the broad general public.
Okay.
Their primary goal, aside from dictating standardized treatment protocols across thousands of clinics, is to prevent unnecessary panic, confusion, and guilt. When a woman is diagnosed with a severe, scarring genital disease, the immediate human reaction is, did I do this to myself?
Did taking birth control cause this permanent damage?
Exactly. So the guidelines are designed to definitively say, no, taking the pill does not cause lichen sclerosus.
Because millions of women take anti-androgenic birth control every single day and never develop lichen sclerosus.
Precisely. The pill is not the root pathogen. The clinical studies in frontiers in clinics and dermatology, however, are examining highly specific, genetically susceptible subgroups. LS has a profound genetic component. Patients frequently carry specific HLA-A, B, and DRB1 polymorphisms.
Wait, what are those polymorphisms actually doing inside the body?
So HLA, or human leukocyte antigen, is essentially the barcode system your immune system uses to distinguish your own healthy cells from foreign invaders.
Okay.
A polymorphism is a genetic typo in that barcode system. So if you have the DRB1 typo, your immune system is pre-primed to make a catastrophic mistake and attack your own tissue.
Got it. So the clinical papers are basically saying, if you have this specific typo in your immune barcode, the pill acts as the stressor that initiates the attack, while the guidelines are saying the pill itself isn't the weapon.
Yes. If we connect this to the bigger picture, lichen sclerosus is fundamentally an immune-mediated disease. The Frontiers update confirms it is driven by a type 1T helper, or Th1 immune response, alongside high levels of a specific microRNA called miR-155.
Okay, let's translate that. How does the attack actually happen?
Think of Th1 cells as your immune system's frontline infantry. They are usually deployed to attack viruses or bacteria. MicroRNAs like miR-155 act like the radio signals directing that infantry.
Okay.
In a patient with LS, that miR-155 radio signal is jammed on full volume, constantly screaming at the Th1 infantry to attack the vulvar skin. It is an autoimmune disease, full stop. It is not fundamentally an endocrine or hormone disorder.
To use an analogy, the hormones are just the environmental weather, but the immune system is the tornado. You can't blame the rain for a tornado, even if they happen at the exact same time. Like, the rain might make the conditions right for a tornado to form, but the tornado itself is doing the damage.
I love that, yes. The anti-androgenic pill is a shift in the weather. The Th1 immune response is the tornado tearing through the tissue.
So, since hormonal treatments are obsolete, and changing your birth control might only remove a trigger, but won't stop an autoimmune tornado that is already touching down, what actually stops the destruction? What is the solution for someone living with LS right now?
The true gold standard, universally agreed upon by the BSVD, the British Association of Dermatologists, and all current clinical updates, is the long-term application of potent or ultra-potent topical corticosteroids.
We are talking about heavy-duty prescription steroid creams.
Very heavy duty. The guidelines specifically mandate brand names like Dermavate, which is clobetasol propionate, or Narisone forte. These are applied directly to the affected vulvar and clitoral skin.
And what's the regimen for that?
The typical regimen starts with a daily application for an initial period, usually a month, followed by a strict tapering schedule down to a maintenance dose, which is usually twice a week, long-term.
And this isn't just a glorified anti-itch cream. The literature is very clear that these steroids physically halt the progression of the disease, right?
Absolutely. The steroids suppress that misdirected Th1 immune infantry we talked about. By shutting down the local immune response, they prevent the permanent loss of anatomy. And alongside the steroids, patients must use emollients as soap substitutes.
Why is that?
Because regular soap is too harsh. It strips the skin and exacerbates microtraumas, which can trigger something called the Koebner response.
Oh, I saw the Koebner response mentioned multiple times in the texts. What is the mechanism behind that?
The Koebner response is the skin's pathological overreaction to trauma. In an autoimmune condition like LS, a tiny scratch, friction from tight clothing, or irritation from harsh soap doesn't just damage the surface cells.
Right.
It rings an inflammatory alarm bell that summons those hyperactive Th1 cells straight to the site of the injury, causing a brand new lichen sclerosus lesion to form exactly where the scratch occurred.
Wow, that makes the physical realities mentioned in these texts incredibly daunting to manage. Because the sources detail severe scarring that leads to clitoral hood fusion, where the skin literally scars over the glands of the clitoris, burying it completely.
Yes, it's very severe.
They mention pseudocysts forming because normal skin secretions get trapped under that thick, scarred hood. How does a patient address these physical complications once the tissue has already fused?
Management requires a highly individualized approach. For clitoral hood fusion, if there are ongoing symptoms or a severe impact on function, the BSSVD guidelines recommend a conservative self-management strategy first.
Okay, what does that involve?
Patients are instructed to apply a 5% lidocaine ointment to completely numb the area, wait 20 minutes, and then gently pull the skin apart twice daily to manually divide the adhesions.
Oh, wow.
Yeah, and this is done concurrently with the topical steroids to help the raw tissue heal properly.
That sounds incredibly painful and just psychologically difficult to manage alone at home.
It is a heavy burden on the patient, no question. And the guidelines acknowledge that it causes stinging and discomfort initially. But for many, this conservative approach can actually prevent the need for invasive surgery.
That makes sense.
However, for selected patients where self-management fails, surgical division of the adhesions becomes necessary.
Yeah, the text mentions surgeons using a needle diathermy to manually burn or cut through the adhesions to reveal the anatomy again.
Yes, this is done under local or general anesthetic and can significantly improve sexual function and relieve those trapped pseudocysts. But surgeons have to be exceptionally careful.
Because of the Koebner response.
Exactly. There is little clinical consensus on the absolute optimal surgical method, primarily because cutting into the tissue carries that massive risk. The surgical trauma itself can trigger a flare-up of the disease, causing the area to scar right back over.
We also have to talk about the ultimate stakes here. Because treating LS isn't just about restoring sexual function or stopping the excruciating itch. The primary goal of long-term adherence to these steroid creams is cancer prevention.
That's right. While lichen sclerosus itself is not cancer, there is approximately a 5% background risk of developing vulval squamous cell carcinoma associated with long-term chronic genital LS.
5%. That's 1 in 20 women with chronic LS facing a potential cancer diagnosis.
It is. And that specific risk profile is exactly why adherence to the ultra-potent topical steroid regimen is completely non-negotiable. The steroids suppress the chronic inflammation that creates the cellular environment where cancer can develop and thrive.
Right.
The steroids are disease-modifying. They are fundamentally altering the cellular environment to prevent malignancy.
So let's summarize the journey of this deep dive for you, the listener. If you read the official patient guidelines, they will assure you that the birth control pill does not cause lichen sclerosus. And fundamentally, they are right. LS is an autoimmune disease driven by a hyperactive immune system and a genetic barcode typo.
Right.
But As we've seen from the nuanced clinical research, if you have that genetic susceptibility and your vulvar tissue naturally lacks androgen receptors, taking an anti-androgenic oral contraceptive can act as the environmental stressor that pulls the rug out from under your cells and triggers the disease. Conversely, progesterone-only methods might offer a slight protective buffer. So what does this all mean? Having this deep dive level of understanding equips you to advocate for yourself in a doctor's office, especially when dealing with a condition that is so frequently dismissed or underdiagnosed. You can walk in and say, I know the pill didn't cause my genetics, but could my anti-androgenic birth control be triggering my flare-ups? That is an incredibly empowering conversation to initiate with your healthcare provider.
It shifts the dynamic entirely. You move from a place of confusion, caught
Yeah.
between contradictory guidelines, to a place of informed, active collaboration in your own treatment plan.
Exactly.
And looking forward, there was one final crucial detail buried in the Frontiers 2023 update that points to where treatments might be heading next. The researchers highlighted that in LS, the affected skin cells are experiencing severe oxidative stress. We were talking about rampant lipid and DNA peroxidation.
Basically, the cells are rusting from the inside out because they are caught in the crossfire of the immune system.
That's exactly it. Our cells naturally produce exhaust-free radicals during normal function. Peroxidation happens when that exhaust isn't cleared out. It starts melting the lipid walls of the cells and mutating the DNA inside them.
Wow.
This severe oxidative stress provides the perfect enabling microenvironment for both the autoimmune disease to thrive and for that 5% risk of cancer to take hold. So, if hormonal shifts are just the trigger, and steroids are just putting out the fire once it starts, it forces us to ask a big question.
What is it?
Could the true future of preventing lichen sclerosus rely on targeted, high-dose antioxidant therapies applied directly to the skin to stop this peroxidation before the tissue ever begins to scar?
Man, that is definitely something to ponder long after this is over. That's all for this deep dive. Take care of yourselves and keep asking the hard questions.